So, good evening, everyone. So today we are going to start with another topic which is really important. We are moving towards the end of the topics that we receive, and these are the two main um classic topics for orthodontics. Okay, so the two topics are preventive and interceptive orthodontics and removal and fixed appliances. Okay, So, so the first thing that we always should remember, as said by Andrews, that orthodontics is 95% diagnosis and 5% mechanics. Okay. Uh, so the questions that we tackle, it is important to remember that whenever you are tackling a question, you need to think about it. 95% is diagnosis. So you have to understand what is the condition that is being given to us, and then you decide upon the appliances, right? Okay. So the question number one is, 4 5 year old child, 5 year old child reports to your clinic with premature loss of primary tooth due to deep caries. On examination, you observe four different situations, right? Which one do you think most requires the space maintainer? So you have four children, all are 5 year old, all have premature loss of primary tooth due to deep caries. Now, these four conditions are being given to you. Which one do you think requires the space maintainer mostly? First is mandibular primary incisor teeth area. I mean the primary tooth loss. Second is mandibular primary canine teeth area. Third is mandibular primary second molar area. And fourth is maxillary primary incisor teeth area. So which of them requires the space maintainer the most? So mandibular primary incisor area is in front, right? Imagine a premature loss, 5 year old. We understand that the permanent incisors are going to come up around 6 to 8 years old, right? He's 5 years old. So obviously he will not require space maintainer. The second is mandibular primary canine teeth area. The third is second molar area and primary incisor. So maxillary primary incisor area, both the incisors areas are eliminated. Okay, maxillary mandible both. Obviously, it's more easier for the maxillary. I mean, space maintainer won't be required, right? Now there are two options: mandibular primary canine area and mandibular second molar area. Now imagine a second molar area. The first molar is about to come up. Second molar has already gone. Patient is 5 year old, 6 to 7 year old, or 6 to 8, we'll take a range, 6 to 8 year old. The first primary molar is going to come up. 5 year, he has lost E. So if we do not give a space maintainer, then what's going to happen is that the 6 would migrate into E space, which has to be succeeded by the premolars, and there won't be space left for the premolar. So the first space maintainer that needs to be given is primary second molar area. Okay, so this is the kind of image that you would see. E has been lost. You'll count the incisors. This is A, B, C, D, and E is lost. 6 is there, but imagine he's 5 year old, so 6 won't be there. It would be about to come up. Even if 6 is there, then also space maintenance is required because 6 would easily migrate. Okay. The second question is, a 6 year old child is brought to the pediatric dental clinic for replacement of an early loss of mandibular second primary molar. The child has a known medical history of congenital heart disease and was previously treated for subacute bacterial endocarditis. Okay, SAB is subacute bacterial endocarditis. The dentist plans to give a space maintainer. Which type of space maintainer should be avoided in the patient considering the medical history? So obviously, there is removable, there is crown and loop, band and loop. All three have one thing in common. It is not very invasive. And we understand subacute bacterial endocarditis, congenital heart disease here. So we do not want to give anything that would be invasive and can cause bacterial infection to reach the bloodstream, right? So in that case, distal shoe is eliminated out. So distal shoe is the answer. Okay. So yes, you can see here, this is a distal shoe. You'll see because the distal arm goes inside the socket, right? Inside the socket of E, so that the 6 has a guiding platform towards its mesial side and it gets into the position. So it is contraindicated in children with history of subacute bacterial endocarditis and other serious cardiac diseases because it involves a subgingival extension. This is the subgingival extension here, which can act as a nidus for bacteremia, right? Introduction of bacteria into the blood. So there's a risk of infective endocarditis, so that we have to avoid. Okay. So the best space maintainer is, whenever this is asked, always remember, see, this is a very short question. Mostly what they will give you in need pattern, in the current need pattern, what they'll give you is a long story. And then this question will be asked, which do you think is the best space maintainer? But if this is given as a separate question, just this much, which is the best space maintainer, then there is no doubts about it. A primary tooth is always the best space maintainer. That is why the pedodontists perform pulpotomy, pulpectomy, whatever they do, because they need to conserve the space. They need to conserve the primary tooth as well, because that's the best space maintainer. If they have a story behind the question, then you have to assess the answer. It could be a distal shoe, it could be a bandal loop, it might be anything, but for in general, it is active space. It's not active space maintainer. It's not passive space maintainer. It's not band loop. The answer is primary tooth. Pulpotomized, pulpectomized, whatever it is, primary tooth. So McDonald's and Avery's Dentistry for Child and Olson book says that maintaining the primary molar by pulp therapy and stainless steel crown is superior to extraction and appliance placement. In any case, Graber and Venisdal for ortho also supports primary tooth can be saved. It should be saved as it maintains the space better than any artificial alternative. So you always remember that. Okay. Now the fourth question is, Jennifer, a 4-year-old child, is brought to the pediatric dental clinic after having her mandibular primary molar extracted due to severe caries. Clinical examination reveals that the permanent first molars have not yet erupted. Okay. The parents are concerned about the maintaining the poor proper space for the future. What is the most appropriate treatment plan? Again, I have always told you that whenever you have this long question, long story behind it, always highlight the points which are really, really important. 4-year-old child. Okay. So first information that you have is that the child is 4-year-old. Came to the pediatric clinic, Falana Dimkana is all story, right? You don't have to remember that. Mandibular second primary molar is extracted. So E is extracted, right? Due to severe caries, very good. Clinical examination reveals that the first molars have not yet erupted. Okay. 6 has not yet come up. So what is the most important treatment plan in this case? That you give a distal shoe. This is a classic distal shoe case that E needs to be extracted and sixes have not erupted, and then you give a distal shoe space maintainer so as to conserve the space for the fives that would eventually come up, right? So this is I just told you a question back that whenever they ask you the best space maintainer for the case, they will always in most of the cases give you a very long story before the question is asked. So in that case, you have to assess, right? Okay. And remember, I want you to remember one thing again. See, this is the case that they are talking about. This is the case that we have to, that 6 has not yet erupted. We need to give a distal shoe extension if it has been extracted, right? If the E has been extracted. So imagine this case, E has been extracted, 6 is about to come up. Here you have a D and you give a distal shoe riding on D, extending to the mesial wall of the 6th, right? Okay. So you'll have this socket, the extraction socket, there the extension, the distal extension will go. Right. So always remember that whenever they are asking you this question, if they mention, okay, that the 6 have erupted, the first hint that they're giving is that the child is 4-year-old. There's no question of 6 eruption, right? So even if they had not said, the question had not said that the 6 have not erupted, you could have guessed that the six have, you would have assumed that the sixes have not yet erupted. Okay. But if you, for an example, they are giving you saying that they're saying that the child is 7 year old, 8 year old, and the six is there, then they ask you the same question. The again, the option that you opt for changes, right? Okay, another question. 9 year old child presents with space loss with a mandibular arch due to early loss of multiple primary molars. 9 year old child, first hint, multiple primary molars have been lost. The permanent molars have drifted mesially. Orthodontist plans to use the lingual holding arch with loops mesial to molar bands as a part of treatment strategy. What is the purpose of this modified appliance in this case? So this question itself I have put because this is giving you a lot of hint for various other questions that may be asked. A 9 year old child, space loss, multiple molar loss, you have to think about lingual arch because the lingual holding arch takes anchorage, takes its support from the erupted incisors. The patient is 9 year old. The incisors have already erupted. First hint. Second hint, multiple more primary molar loss. So you can't put band and loop also because there is multiple loss of molars, right? So you have to rely on something else. The answer is if the question ended here and they asked you which is the best space maintainer, the answer would be lingual holding arch, right? But they have already told you that the lingual holding arch is given. They are asking why the orthodontist has given this arch. Is it for correction? Is it for regaining space, which is the second option? Is it for space maintenance only, which is the third option? And the fourth option, correction of distally tilted molars. First of all, why would the molars distally tilt? I mean, they would mesially tilt, right? So this option is eliminated out, right? Then they are saying, is it for space maintenance only? Or is it for correction? See, we are not trying to correct anything. Okay, so that option is also eliminated out. There are two options remaining: regaining space and space maintenance only. Why would they write loops placed mesial to molar bands? There must be some thought process behind it. Why didn't they just say lingual holding arch? So the question itself is giving you some hint. Always remember, half of the answer is there in the question only. You know the purpose of the lingual holding arch. If that was the case, why would they tell you that the loops have been placed mesial to the molar bands? Okay. So these loops help us to distalize the molar a little bit. So we can regain space with that. And we can also control the, sometimes if it is required, we can also control the buccal and lingual movement of the molars as well with these loops, right? So that is why, that is the uh, purpose of those loops. So the answer is regaining space. Okay. So this, I just wanted you to remember the fact. So this was given, lingual arch was given by George Crozat in 1900. Then Walter Coffin is often credited for developing the earliest version of fixed lingual arch. So before that, it was removable. The Crozat gave the removable arch, and the Walter Coffin gave you the fixed lingual arch. Okay, you'll always remember from Coffin Spring. So that was also a palatal appliance. This is also a lingual appliance. Okay. Okay. Next question. A 7 year old child is brought to the dental clinic for routine orthodontic assessment. Very good. Parents ask about the measures that can help prevent the need for future orthodontic development. Very good. Which of the following procedures does not fall under preventive orthodontics and is instead a part of interceptive orthodontics? So the question has made it easier for you. They could have easily asked, ended the question in the first half, need for future orthodontic treatment, prevent the need for future orthodontic treatment, and asked you which of the following procedures does not fall in that case. But they had, so I give you a hint. They are asking is, it should be a part of preventive orthodontics and not be interceptive orthodontics. So the list should be clear to you what all is preventive orthodontics, what all is interceptive orthodontics. Even if you don't remember it by heart, doesn't matter. You just have to think before the answer. Are we preventing something, or are we trying to intercept a malocclusion which is already being developed? Okay. So now the question is, which of the following procedures does not fall in the preventive orthodontic case? Instead is so it's vice versa. So you have to remember that which of this is a process that is being introduced when the malocclusion is seen by the dentist and you see it happening and you try to intercept it, right? That process we have to highlight. Okay. So, which of the following does not fall? Is topical fluoride application preventive or interceptive? Do we apply it when we see something or before we see anything? The answer is before we see anything, we apply topical fluoride. We do not wait to see any caries or something like that. And if we see it, then we don't apply, then it makes no sense. Right? Thumb sucking correction. Do we correct thumb sucking after something has taken place, or we just see the age of the patient and we intercept? We try to stop the habit. Are we changing? Are we introducing any appliance to correct the situation? Is thumb sucking a malocclusion? No. Are we trying to intercept the malocclusion? No. So thumb sucking is not the answer. C is lip guard. Anyway, we are not trying to intercept anything. D is serial extraction. So what you do is you see that the malocclusion is developing. You see there is not much space. You do the model analysis. You analyze that, okay, in future there will be crowding when all the permanent erupt, and you decide upon to go for serial extraction. Right. That is a part of interceptive orthodontics, not preventive orthodontics. We are intercepting the malocclusion. So preventive orthodontics, as I said, are steps taken before the development of malocclusion. Interceptive orthodontics is when measures are taken to intervene in early developing malocclusion. Okay. So correction of thumb sucking is not, it is falsely mentioned here. It should be correction of malocclusion developed by the thumb sucking habit. So you see that the incisors are getting proclined, you stop the habit and you give some appliance, that is interceptive orthodontics. Space maintainers, fluoride application, diet counseling, lip guard, these are all preventive. If we do not give space maintainer, the malocclusion will develop. If you give something such as an appliance, you try to regain the space, that could be termed as interceptive. Otherwise, it is all preventive orthodontics. Serial extraction, crossbite correction, developing crossbite correction again, developing crossbite correction, okay, are all interceptive orthodontics. In quad helix appliance, activation of anterior helices produce no expansion at all, posterior expansion, both anterior posterior expansion, anterior expansion. Okay. So for that, I want you to see the appliance as well. This is the quad helix. So 4 helix, hence the name quad helix. So here you can see these are the entire anterior helices. These are the posterior helices. So once you open these helix, this arms move outward, right? Okay. Once you activate these helices, so this arm moves outward. This arm goes till here. Same goes for this arm also. So whenever the question is activation of anterior helices produce no expansion at all, of course, that's incorrect. Both anterior and posterior expansion, anterior expansion. Okay. So imagine this arm is constant, right? We are not changing here. This arm we are not changing. This element. We are opening this helix. So this arm moves here, this arm moves here. So can you imagine that this arm will come here, right? So no pushing it outward in the anterior region. So no expansion in the anterior region. This arm goes outward, so the molars get expanded. So hence the answer would be that the posterior get expanded. So there are many ways of activation of quad helix. So I just want you to remember the facts. Ricketts was the one to give you quad helix 1975. It was a modification of a coffin spring. So it is playing the same role, right? Slow expansion. It has 4 helices, four helical loops, 2 incorporated in the posterior region, 2 incorporated in the anterior region. The appliance is constructed with 0.38-inch stainless steel wire. Bands are soldered, right, on the deciduous, second molars or maxillary, first permanent molars, okay, depending upon the age of the patient. Another way of activating this quad helix is through three-prong plier. Okay, the three dots that you see here is the top. If you are viewing from the top, okay. So this is the anterior arm, right? So here if you introduce the three-prong plier here also, then there is also expansion. You can see this was the molar region. It has expanded and it has caused rotation also. Okay, so these things have to be in mind. This is how we utilize the expansion of quad helix to cause effects and to negate the effects. Okay. So remember, these are not activating the helices. These three-prong pliers are activating the arms. They are introduced in the arms. Do you see the bend here, the sharp bends here, and in the anterior region, this is three-prong plier. So what we generally do is we try to open up the helices, and to negate the other effects, we introduce the effect of three-prong pliers also. So if we introduce three-prong plier here, we see that there is some amount of this is the molars get derotated, right? The molar derotation is excused and the anterior's expansion is introduced. So first activation here in the anterior region, which causes expansion of the posterior, but also causes rotation of the molar. Second activation, derotation is there is derotation, hence the rotation that was caused earlier by the introduction of a bend in the anterior arm is negated. It has derotated, right? And there is some expansion in the anterior region as well. So this is how you utilize that. So quad helix activation method, there are two methods, either extraoral or intraoral. Extraoral, this is preferred method, but then you have to see, you have seated the appliance, then you have to take it out and then again activate and then put it back. So activation of anterior helices. So whenever helices have to be activated, the appliance has to be taken out of the mouth, right? You cannot, I mean, how will you activate the helices while the appliance still lies in the mouth? Because in that case, you also do not know how much force have you applied, right? So, and whenever intraoral activation has to be taken place, this method utilizes three-prong pliers, the way I told you, right? And we introduce a bend. So anterior bridge, if there's a first band in the anterior bridge, single peak of the plier, I mean, single beak is towards the front, right? That's what they're telling. The second and third bends are made on the palatal bridges. Palatal bridges are these bridges, right? So this is the anterior, these are the palatal, right? Okay. Easily on both the posterior bridges, right? So this is how a quad helix works. So the answer that we had to be given. So I introduced all the bends and all the methods of activation. So remember, always remember, if the anteriors are activated, the posteriors expand. If the posteriors are activated, the anteriors expand. If bends are given, what kind of bend is given, that causes a different kind of rotations and expansion. So that needs to be taken care how the bend is given. Okay. Anterior bite plane is used for the correction of anterior cross bite, deep bite, open bite, all of the above. Okay, so look at this picture on the right side. We have introduced the picture here only. This is an anterior bite plane. So what you can see, what all can you see? Okay, there is some posterior open bite which has been reduced because the anterior mandibular anterior are hitting the bite plane which has been seated on the upper anterior, right? So what will they cause? So whenever a bite is introduced, always remember there are some forces which are applied, right? And the forces are because when we masticate, the lower will hit the bite, right? So intrusive forces are applied. I mean, lower will hit the bite will in turn hit the upper, and upper intrusion will be caused. And what will happen is that the lower hit the bite, they cannot go further, but there's a gap, the muscles would try to bite, and there is an intrusive force, opposite force, which is being applied on the, I mean, on the here in the downward direction. So action, always remember third law, action and reaction. So on both the arches there is some intrusive force, but imagine, I mean, just imagine the maxillary anteriors with their broader roots, more larger roots, they would be intruded to a lesser extent as compared to the lowers which have more slender. I mean, You cannot even compare. They are much more slender than the uppers, and hence there is intrusion of the upper and lower majorly. So whatever happens, I mean, if the upper intrude or the lower intrude or both of them intrude, one thing is definitely solved, which is the deep bite. So anterior cross bite cannot be solved with this, because for anterior cross bite, we need free space in the anterior. So we'll give you a posterior bite plane, and then we have free space in the anterior, and hence anterior cross bite can be corrected. For the open bite, I mean, imagine an open bite with the gap in the front, and you introduce a bite plane that will cause intrusive forces that will further open the bite. Okay, so that is not the answer. All of the above is definitely not the answer. D bite is the answer. Okay, posterior bite plane is used in correcting. I deliberately posted this question because I mean, this is what I explained. Whenever the posterior bite is given, posterior bite plane is given, obviously anterior cross bite needs to be solved. Always remember, whenever a bite is being given, whatever movement you want in the buccal palatal direction or in the mesial direction or the lateral direction, mesial or distal direction, whenever the bite is given, that side, the bite also interferes with the movement. So, I mean, imagine if you're trying to move the molar in the buccal direction or the palatal direction, and you're given the bite on the molar itself, the bite itself will interfere with the movement. So the logic also says that whenever you're trying to move buccal or palatal, the posterior teeth, it is better that you introduce the bite in the front. Whenever you're trying to cause the movement in the front, introduce the bite in the posterior region. It is as simple as that. Okay. But whenever you're trying to intrude that kind of forces you are trying to apply. So remember that the bite causes intrusion forces. Okay. So that is why in aligner patient, in a lot of aligner patient, you'll see posterior open bites. Okay, because there is a bite which is coming in the posterior region, right? So always remember, for bite, wherever you want to intrude, you give it there. You want to intrude the posterior, give it there. You want to intrude the anterior, give it there. Okay? Amen. Always remember. Okay. So here you can see there was anterior cross bite. What do? You give the bite in the posterior, let the anteriors be free, and finally correct the anterior. Okay, so this is the bite in the posterior region here. Okay. Anchorage in removable appliances is provided by acrylic base only, teeth, acrylic base and teeth, and retentive glass. So anchorage in the removable appliances, always remember that whenever we are taking anchorage, we take mostly orthodontic tooth movement is caused in the teeth, and we take help of teeth or some other things. For an example, sometimes we take help of mini implants, for an example, DATs. But mostly when we are doing orthodontic treatment, we use teeth. So you might get attracted by this option. Okay, removable appliances, we are talking about here. So the answer would be teeth only, because we take anchorage from teeth, whether it is reciprocal anchorage, stationary anchorage, whatever it is. But always remember that this is a removable appliance that they're talking about. It will always have an acrylic base. Okay, so it is not only teeth, but sometimes acrylic base. I mean, acrylic base will go against the palate and give you some kind of anchorage. Okay, force maintain at some appreciable fraction of the original from one patient visit to the next. So a force is being maintained for the in the original form, whatever force was given. For an example, 5 Newton force was given. The patient comes to you after to another visit. You always take, imagine, just don't get lost in the question. Whatever hi-fi language they use, just apply a simple logic, simple example. A patient comes to you, you give 5 Newton force, you send the patient home. The patient comes to another, comes for another visit next month, and patient still has 4 to 5 Newton forces. So the applied force, which is continuously going on for a long time. The answer is in front of you. This is not intermittent. This is not interrupted. This is continuous force. Okay, always remember. But I want you to let's develop some idea so that we never get confused in continuous, interrupted, intermittent forces. Okay, let's just solve this confusion here and now. You should never be confused in the exam, okay, whether it was interrupted force, whether it was intermittent force, whether it was continuous force. So You will see, you will never get confused between continuous and interrupted and intermittent. You will always get confused between interrupted and intermittent. You'll always get confused. So let's solve it here. Interrupted is, it is an orthodontic orthopedic force that is inactive for intervals between the appointments. When compared to continuous, the interrupted forces are of shorter duration. Usually heavy forces, for example, headgear and face masks are the prime example that they're here. Okay. For a period of 10 to this thing, 10 to 14 hours a day. So this is interrupted. So I want you to remember this. I want you to look at the graph. Look here. Continuous would have a straight line. So a low amount of force for a continuous period. So on x-axis, always remember this is time, okay? This is the magnitude of force. On y-axis, this is time. So when the magnitude of the force is constant, doesn't change with time much, this is continuous force. Okay. Okay, the second is interrupted. The B option here is interrupted. You apply some force, it goes down, comes to 0 at some point of time. Then you again apply, it directly rises from 0 to 10, then goes back. I mean, 10 is just an example. I just want you to know that will suddenly rise to some other thing. And then again, then we'll go on a few, like for a few hours and then it'll. So this is interrupted. Intermittent is, imagine a patient with tachycardia. Always remember like that, like zigzag. Okay. This is intermittent. Decline to 0 magnitude prior to next appointment, and then you activate it again, and then it slowly goes down, and then 0, then again, then you apply some force, then okay. So in some books, what you'll see is, and in some questions also, you'll see a graph instead of this lines. You'll see a graph. Graph would be something like here, constant force 0, constant force 0, constant force 0. Or something like this. So let's understand that whenever uh, you are looking at these two options, that is interrupted and intermittent, to solve your problem, always remember the example associated. See, here they are saying headgear and face mask. So orthopedic. Interrupted is orthopedic. Intermittent, they are saying removable appliance. Always remember, interrupted is not removable. It has R, but not removable appliances. Orthopedic exam is the exam. So you wear the elastic, you pull the elastic out, it drops to 0. Then you wear the elastic again, and suddenly there is rise. Okay, and then it drops to 0. Okay, when you remove it. So yeah, it'll slowly decline to, I mean, it will suddenly decline to 0, and then you apply, and then it suddenly declines to 0, and then you apply, and something like that. Intermittent would slowly, it will give you a heavy force, then it slowly falls to 0. Then again, you activate it, then it slowly falls to 0. Then again, you activate it, then it slowly falls to 0. The example is removal. Okay. So remember, when you have double R, you cannot have another R. I just remember by that thing that when you already have two R's, you do not need another R. So removable appliances will not have the example of interrupted. You will not have another R. So the option they are saying, even if they say that this is a removable appliance, what kind of force are you expecting? Okay, you see, okay, 2 R's here. I do not need another R. Okay. So the answer is okay. I know it's a very stupid thing to remember, but I just wanted. Yeah. Australian wire is a round austenitic wire, most commonly used with Beck's differential light force technique, and it is manufactured. Okay, this is a very, I would say this is a very rare question, and this is a little higher level than your. I mean, I do not consider this as UG level. This is very, very well taught in your post graduation. If you go on to become an orthodontist, then it is very well taught. But then it is an old technique. Pegs is an old technique. It used to be, it was used uh, maybe during the time of your readers when they were student, or professors when they were student. Okay, at that point of time it's used. But since it has been asked once, so I'll just tell you once. Okay. So Australian wire, is it heat treated, cold drawn, cold treated, heat drawn, annealed and cold drawn, spring drawn, cold treated? So Australian wire is nothing but stainless steel wire, which has been heat treated and cold drawn. Okay. So I'll give you a racist example for this, but I just want you to somehow remember the facts. So first I'll tell you the story. So what was happening was that Dr. Beggs introduced Australian wire. He was the first to use. So Beggs is a philosophy such as MBT philosophy. Beggs is also a technique of correcting orthodontic problems. So he was basically a student of angles. So to practice, he went to Australia. In Australia, he observed cavemen and their teeth, and from that inspiration, he derived his technique, which was called Beck's technique. Okay. And at that, for his technique, he was looking for some wires, a particular type of wire, which would cause that particular type of movement. Why was he looking for that? Because he was, for angles, he had this problem that he used to think that, okay, okay, my guru was right, everything was good, but it is taking a lot of time. It is causing a lot of relapse. So hence, he went on, and always remember that angle was always non-extraction proponent. He always believed in non-extraction treatment. He was all in for natural. Beck was not like that. Beck wanted extraction. He was okay with extraction. So he wanted something. He wanted to solve the orthodontic movement quickly and extraction, because extraction would take a lot of time. Once extraction case is done, it will take a lot of time. So he wanted something, I mean, treatment to happen quicker. He met AJ Wilcock, Arthur J. Wilcock. So these wires are also called AJ Wilcock wires. So do not get confused. Bags, AJ Wilcock, Australian wires, because he was from Australia. The technique developed in Australia. That is why they are also known. And the wire also, Wilcock was also from Australia. So the wires also developed in Australia. So that is why they are known as Australian wires. So Wilcock produced cold drawn, heat treated. So stainless steel, you all remember, is shiny. So you basically roast it. So whenever you roast a thing, you roast a corn, it becomes black, yellow to black, right? So stainless steel roasted, it became black. So always remember it is heat treated and then cold drawn. Okay. Strike balance between hardness and resilience, and that is why he developed it. He started supplying these wires to Mr. Beggs, and that is how. So it was more resilient, more hard. So force was there for, it was resilient. So force was there for a longer time without reactivation. So over long distance, that's what Mr. Begg was seeking. He wanted to limit the number of visits, right? So the next question is, Catlin's appliance is used for the correction of, is it anterior, it is deep bite, is it deep bite, is it anterior cross bite, thumb sucking habit, or lip biting habit? Okay. If you know what Catlin's appliance is, you will have no problem answering this question. Catlin's appliance is basically this, look here. So whenever you see a developing anterior cross bite, what do you do? Remember, if you see it is developing, the incisors are still erupting, and it is in very, very initial stage, you have to, you can go for tongue blade therapy. Basically, tongue blade is that you take an ice cream stick and ask the patient to bite upon it. So it applies a force in the lingual direction on the lowers and on a buccal direction on the uppers. That is treated. If the another option you have is that you give a Catalan's appliance. So you basically give a reverse bite plane kind of thing in the anterior lower region. This angle is 45 degree. Always remember, this angle is 45 degree. And whenever the patient bites, you can imagine that this will slide on this in this direction. So, and due to this, a reverse action reaction theory, the reverse action is applied on the lowers also. So the lower go lingually, the upper go buccally, and hence the anterior crossbite is solved. So okay, this is Catalan's. Another appliance that you can give is Hollies with Z spring maybe. That will push the anteriors, the upper anteriors out. It will not do anything to the lowers, but it'll push the upper anterior. Okay. So these are the three appliances that can be used. Okay. Whenever you see a anterior prospect, always remember 45 degrees. Okay. Removable appliances bring about bodily movements, translation, tipping, derotation. Okay. Oh. See, two options. See, we all know that removable appliances cause tipping. Imagine, I mean, if removable appliances were capable of translation, I mean, then why would anybody introduce a bonded appliance, a fixed appliance, braces? Why would we introduce if braces? It is very difficult to apply. I mean, do bodily movement or translation with. I mean, braces also. And imagine they are saying removable appliances. Will they be able to do? Right. So see, whenever the force is being, you all know that whenever the force is being applied away from the center of the resistance, then you know that tipping will be caused. Hence, the answer is tipping. Because we cannot, it is very, very difficult to introduce a reverse torque, which is how we do it in braces. I mean, torque is generated towards the root, and that is how we cause volume movements in the braces, and that too it is very, very difficult, right? So here they have nothing like that. So torquing is very, very difficult in removable appliances, mostly cause tipping. Okay, derotation is also very, very difficult to achieve. Okay. Which of the following clasp is preferable on a partially erupted tooth for adequate retention in the removable orthodontic appliance? You don't have to guess. Best is Adam's tips, and that is why it is used in many, many removable appliances in the uh, see, because mostly removable appliances we are giving to kids. Okay, so Adam's appliance works well when I mean, it is the best way to engage the undercut, the buccal undercut, and hence it is very good for this thing, partially erupted tooth also, because the arrowheads also go inside and they can engage the undercut. Okay. Which of the following is correct? Z spring or double cantilever spring is used for labial movement of incisors, minor rotation of incisor. Okay, Z spring. So we all know, I hope everybody remembers the diagram. Okay, this is the Z spring. T spring is used for the buccal movement of the premolars and sometimes canine. Okay, T spring, flapper spring, whatever you call it, something like that. My drawing is really bad. Ignore that. But yeah, something like this. Okay. Coffin spring is a removable type of expansion spring. Okay, very good. Coffin spring, yeah, we all know that's a removable type. No doubts in that, because acrylic plate is here and here, and between there is a coffin spring. Canine retractors are springs that are used to move canines in a distal direction. Very good. One of the canine, you look canine retractor, imagine here. That is how it looks. Engaging the canine. Right? So we retract the canine in this direction, distal direction. Yes, that's absolutely true. So whenever you see that there are two options that you are very sure of that are correct, you automatically go to all of these. So yes. Which of the following is correct? U-loop canine retractor is least effective and is used when a minimal retraction of 1 to 2 mm is required. Okay, that is a very logical question. I'll tell you why. Helical canine retractor or reverse loop canine retractor is indicated in patients with shallow sulcus depth. Also connect that back. Palatal canine retractor is indicated for retraction of palatally placed canine. Buccal canine retractor is retraction for buccally placed canine. Okay, these two options are correct. So you automatically go for all of the above. But I want to talk to you about this fact, that why U-loop canine retractor is least effective and is used for minimal retraction only, whereas helical canine, and why helical canine retractor is used for shallow sulcus depth. I don't want you to, rote learn this thing. I want you to understand why this is the thing, why this fact exists. So we always remember that whenever we are trying to see the forces in orthodontic, these removable appliances, we always remember this formula. That force is directly proportional. B3. I mean, even if we forget the powers, I mean, We all know that force is directly proportional to the diameter of the wire. I mean, there's nothing so great Newtony about it. I mean, if the wire is thicker, the diameter of the wire is greater, right? Hence, the force is also greater. I mean, imagine a very sleeky, the ender wire. How much amount of force will it apply? What do you think? This wire, or I mean, this wire. Which wire do you think will apply more force? All of you will say, okay, sir, thicker wire. Absolutely, absolutely correct. So we always remember, okay, D is up, D is the numerator, and we understand L automatically becomes the denominator. So force is indirectly proportional to L. The more the length of the wire, lesser is the force. Now, U loop canine retractor. Okay, this is a buccal canine retractor. This is U loop canine. Okay, here. This is U loop canine retractor. Okay, here. Now imagine this length. If I straighten it, I think this is the entire length. Right. This is helical canine retractor. Look at this. Okay, okay, okay. Imagine this we straighten it out maybe around this much. I mean, whatever it is, this helix is helix. If this had been U loop, this helix would not be here. This would wire would be straight like this. Now imagine you have introduced a helix here. The length of the wire has increased. Yes or no? Absolutely yes. The length of the wire is increased. And we all know that the length of the wire, the force of the wire is indirectly proportional to the length of the wire. So length of the wire is increased, hence force of the wire is decreased. Now, that means to apply the same force, you'll have to bend this very, very much as compared to this. This will easily apply the same. And hence the force will be low, continuous. I mean, imagine you retract the, you compress this loop here till here and then engage this canine, open it up, how much amount of force it will apply? Whereas since you have increased the length of the wire in the same loop, the force applied is less, hence more bearable, hence low continuous, hence easier movement. To reduce the force equally, you will have to equal the length of the wire, hence this loop will go like this. If you have to make sure that the length of both these loops, the wire required to make both these loops are equal in length, these two loops equal in length, you have to make this loop much deeper. That means that in a patient which has shallow sulcus depth, it is better to introduce helical canine retractor, because otherwise to apply low forces, you will deepen this loop and then it will impinge in the vestibule, right? So it is better that we give helical canine retractor, right? U loop canine retractor least effective because minimum retraction is required, minimal retraction is required. It is introduced, it is used when minimal retraction, because we cannot reduce this loop too much, because it otherwise it will apply a large amount of force. So what we do is just compress it till here and then engage it here. So only this much retraction could be done, because otherwise force will be too high. That we do not want. Okay, unnatural amount of force. Too much force we do not want in orthodontics. Always we prefer low continuity. Which of the following concept is correct? High label bow is used mainly to carry auxiliary apron spring and is indicated for retraction of anterior with large overjet. Okay, something auxiliary, high label bow. Okay. Robert's retractor is indicated in patients having severe anterior proclination, mainly canine with overjet of 4 mm. Mills retractor or extended label bow is extended in patients with large overjet. Fitted label bow is used as a retainer for completion of fixed orthodontic theory. Okay, so I have introduced this question not for you to remember as a question, but the facts related to it. So the use of various retractors. So this is based on, this is a very old question. Most probably it won't be asked, but then also I want you to remember, okay? What is the use of these kind of retractors? So high label bow with auxiliary apron spring, retraction of anterior with large overjet, okay? When the overjet is large. Robert's retractor indicated patients having severe anterior, so anterior proclination, Robert's retractor, mainly with canine. Okay. With overjet of 4 mm. Okay, not very large. Mills retractor extended labial bow is indicated in patients with large overjet. Okay, super. Fiddle labial bow is used and written as a after at the completion of the fixed orthodontics. So fixed orthodontic treatment, you do not want the teeth to move at all. So you give a fitted labial bow, so no teeth will move at all. So there is no scope. Disadvantages of removable orthodontic appliance may not be worn by the patient. Of course, it is totally dependent upon the compliance of the patient. So, may not be worn by the patient. Yeah, that can happen. Inability to control root position. Obviously, I told you, removable appliances, torquing is very difficult, very difficult to control. Okay. Has a fail-safe effect. Okay. So, two options are correct. A and B. There is no question for fail-safe effect. C. Fail-safe effect is basically that whenever you are trying to apply some force, it is in control. That is true for the removable. Whatever, I mean, imagine this canine retractor, whatever I told you, if you deactivated this much, you close the loop here, you close the loop till here, and then engage the canine here, the canine will only move from here to here. It will not keep on moving if for an example, the patient does not visit you for 4 months. You just want the canine to from canine for the canine to move from here to here, for an example. It is not in your control. Imagine you introduce a E-chain here. Okay. You introduce a E-chain here from canine going to a TAD. The E-chain will keep on applying its force till it has the elasticity. It does not matter to the E-chain how much you want to move the canine. But here it is in full control. If the patient doesn't come to you for another year, the canine will only move till here. It will not go anywhere else. Okay, so that's the fail-safe mechanism. That is also there in loop mechanics in fixed orthodontic therapy also. Okay. So the first orthodontic appliance devised by Angle was, it is a historical question, edgewise, pin and tube, E-arch, ribbon arch. I just want you to, so I made these other slide. So I just want you to remember that what was the thing that he was doing. Okay. So E-arch was the first. Always remember, E-arch was the first appliance. Then he developed pin and tube. Then he developed ribbon arch. And finally, while developing edgewise appliance, sadly, he passed away. Okay, so edgewise was his last development, and he was just writing, like he was just finishing developing it, so he couldn't even like finish it. But yeah, that was the last thing that he developed. So always remember, E first, E last. E arch, E A. So A, E first. Okay, so E arch appliance was the first. Then comes P, then R, P R always. So pin and tube and ribbon arch. And finally, I said E first and E last. So E last is edgewise. Okay, so I just want you to have these photographs so that it doesn't confuse you. Maybe they'll give you photographs and ask, okay, this is the first E arch. Okay, so there's an arch. Nothing much about this. Then always remember pin PR. So pin and tube. So this is a pin which is engaged in the wire, which is soldered to the wire. So welded to the wire. And here, do you see a band around the teeth? It used to have a hollow pipe sort of thing, hollow tube sort of thing, and hence the name pin and tube. So the wire would have a pin, and these bands around the incisors would have a hollow tube. The pin would engage, and hence would be able to cause torquing. Imagine torquing was possible due to this. Then came ribbon arch. So this this is again band. So at that point of time, bonding was not discovered. So they used to band. They used to band a lot. Okay. So this is ribbon arch. So this is further development. And finally, the last, which is the edgewise. So edgewise would always have edgewise. This is the edgewise here. They will have, imagine if this bracket was also there, same thing was here. So this would look like a modern day bracket, right? So yeah, this is edgewise. This is the last appliance that it was developing. A slot, a vertical bracket, and there's a horizontal slot. Okay. Which is the type of the wire formed by twisting 5 tempered wire over a common wire? Okay, this is also a very factual question. Is it twisted wire, braided wire, axial wire, or coaxial wire? Okay. This is a very, very confusing question. Okay. This is a coaxial wire. So twisting 5 tempered wire over a common wire, common axial around the axis. So around the common wire, coaxial wire. Okay. This is the answer. These are the options that they are talking about. So braided, so coaxial wire is central core, 5 twisted wire around here. Here it is. A central core and 5 wires around, 5 to 6 wires around it. Highly flexible, early alignment. Okay. Braided wire, weaving of around 8 strands. So this would mostly be rectangular. It could be circular also, but mostly rectangular it is. Can you see these braids here? Okay. So these are braids. You can see the pattern here also. This is braided. Okay. Flexible but good torque control. Since they are rectangular, so they'll have a better torque control, right? Third is twisted. 3 strands twisted together, moderate flexibility and strength. Here, triple flex. 3 strands twisted together. So that is the difference. Always. Okay, always remember. Okay. Important question, important topic actually. 18-8 stainless steel. What is 18? What is 8? What is stainless steel? These are important questions to answer. Of course, the answer is 18% chromium and 8% nickel. But I wanted to understand what steel is. Steel is basically iron. Iron had a problem. Iron would rust. So they wanted something that would not rust and hence not stain. So they developed a iron which would not stain and called it stainless steel. How did they do so? They basically introduced carbon. So carbon, the problem, but just carbon was not enough. Carbon gave it good mechanical properties, but it was not stainless. So introduction of carbon gave the iron some strength. So it was called steel. So whenever iron is mixed with carbon, it is called steel. Steel is the alloy that they are talking about. When at the point, but it would again stain. It could not keep them rust free. I mean, not stainless. So stainless steel plates that you see at your home, they have been washed since I don't know how many years, and still they remain the same. Have you ever seen them resting? No. So what they introduced was chromium. Chromium had this effect of passivation. So chromium in contact with oxygen would form chromium oxide, which would stick on the surface and prevent this iron from getting rusted. Okay, so that is stainless steel. But I also want you to remember a few things. There are various types of stainless steel. Mainly 3 types I want you to remember: austenitic, martensitic, and ferritic. A very easy formula to remember. For you to remember, always remember F for ferritic, F for faltu. Okay. Either faltu or friendly. A friend is of no use to you. Right? They would not come in handy. I mean, not every friend, but just imagine like a bad friend he is. Okay. So he is of no use. He is there just to have fun. Okay. So F for friendly, F for faltu, F for ferritic. So ferritic has limited uses on orthodontics. Not much. Okay. M for martensitic and A for austenitic. So A for austenitic, I want you to remember that A is used in arch wires. So A for austenitic, A for arch wire. And A for arm. Arm means common. It's very common. It's most commonly used. So austenitic wire, austenitic stainless steel is the most commonly used stainless steel. It is found in arch wires. Okay, brackets, band, ligatures, so mostly austenitic. M for martensitic, M for mazboot. Mazboot it's a Hindi word which means like it has a lot of strength. So whenever we have to provide a person with strength, he has to go through tough times, right? So whenever austenitic is quenched, it becomes martensitic. So a hard stainless steel, whenever you need, it goes by the name martensitic. But so cutting instruments, so it will not dull easily in the sense it will not bend for a long time. It is very hard. It's so whenever some quality is given by God, then some qualities are compromised. So when martensitic was provided with hardness, It's, I mean, it's rusting, anti-rusting, stainless steel, stainless properties declined. It was given hardness, but yes. So it was not stable that way. It would stain easily. So the corrosion resistance properties were not very good. Okay. So cutting instruments is used because, I mean, imagine a surgical blade is made up of austenitic because we want it sharp, we want it hard. Okay, a hard blade would not bend. The edges is very, very thin, right? For a blade, for a sword, the edges are very, very thin. If it bends, it will not cut. So a scalpel is made out of martensitic stainless steel so that it remains hard. But do we require anti-rust properties? I mean, corrosion resistance properties that much? No, you're going to use it on single patient, then throw it out. So yeah, corrosion resistance properties is compromised, but that's okay. For austenitic, imagine austenitic. Austenitic arch wires will be there in the patient's mouth for, I don't know, for a year, at least for three months, maybe maximum 3 months, 1 to 3 months. If it starts rusting there, the corrosion resistance properties is not that good, then what happens? So remember, and always remember that prosto case in which you used to keep a scalpel. Okay, with a surgical blade, the scalpel and this blade handle, you would see that after one posting, the scalpel would start rusting, right? So always remember that is martensitic, it will rust. Austenitic is common, is arm, is arch wire, A for arm, A for austenitic. Okay, remember that thing. Ferritic, not much else. Which of the following correctly matches the order of bends in edgewise appliance? So MBT, or we would say that the philosophies, the techniques, the orthodontic techniques in which everything is not pre-introduced, which we call as pre-adjusted edgewise. So it has been pre-adjusted. They are saying simple edgewise. So the first edgewise that the angle developed pre-adjusted edgewise. In those, nothing is introduced in the bracket. Whatever kind of movement that you need to do has to be done through wires, through wire bending. So at that point of time, wire bending was much necessary. Okay. So they are asking what is first order bend, what is second order bend, what is third order bend. All it's easy to answer, very, very easy to answer. Remember, see here. If we look at from the front of the patient, will you see two different wires, or will you see a single continuous wire like that? If we imagine it from the front, obviously you'll see a single wire. This is in-out bend. You will not see in-out in 2D, right? Right. So this is there in a single floor. I would say the wire is there in single floors. This is first order bend, in-out bends. Now, here we are looking at from the front and we see two different wire levels here, here, and again here, and then again here. So two different levels, right? So this is second order. The torquing is third order. So whenever vertical bends are introduced, it becomes second order. Whenever in-out bends are introduced, it is first order. And whenever torquing, we are talking about torquing, then third order bends. So basically 3 levels of wire, 1, 2. Okay. So I mean, that's not the logic. That is somehow we remember. But obviously third is never the confusing part. The confusing part is always first and second. Okay. Okay, lot of image-based question in fixed orthodontics. Here, look at this. Which plier is shown in the image? Is it universal? Is it tweed? Is it light wire? None of the above. Okay. So whenever you do not know the plier, at least eliminate out the pliers that you know of. Is it universal? Definitely not. This is right. We are left with two, light wire or tweeds. Okay. For this, we have no logic for you to remember. It's just image-based. You have to remember this is a tweeds plier. Okay, we use it. Tweeds was a technique which came after edgewise, and it was a very, very important philosophy. So you used to use pliers for the wire bending. So these are those pliers, tweeds pliers. Okay, we call them tweeds pliers. Okay, the answer is tweeds. What will be the effective force if the diameter of the wire is doubled? L3 by D4. Okay, so if the wire is doubled, 2 raised to power 3. So 2 to the 4 to the 8 times. Okay. Identify the pick. Which plier is it? Is it bracket holding? Is it debonding plier? Is it band placement? Okay, very sleek wire, sleek plier cannot be band placement. Okay, debonding plier. Do we see any edges for the for it to engage the bracket and the composite? No, not debonding plier. Bracket holding looks like a tweezer. It's not a bracket holding, it is Matthew. Okay, it is a very common plier that we use in orthodontics. We use it for like E-chain, pulling the E-chain, for a lot of other purposes, for putting the module, for everything we use Matthew. Okay, so it is a very common plier. I want you to remember. Okay, now here we see the edges. Edges. Do you see these sharp edges that it has to engage the bracket from behind the wing and engage the composite? Okay, so this is not bracket holding. This is not bracket holding, not band placement, not band holder, nothing like that. It is debonding plier. Okay. Okay, fixed again. What are these elastic bands used for? Image elastic bands on the teeth. Okay, this is the elastic band there. Mode. Okay, these are elastics. Is it being used for posterior crossbite correction? I don't think so. Do you see any posterior crossbite? I don't see any posterior crossbite. Okay. Do you see a midline diastema? No, I do not see a midline diastema here. So no, these two options are correct there. Anterior open bite, are we using for anterior open bite? For anterior open bite, we use elastic ear to ear so that a force is applied in the upward direction towards the occlusal direction, and hence open bite is corrected. Extrusive forces are applied on the teeth. Here also we say extrusive forces are applied, but it has a vector in the horizontal direction too. And hence, this is occlusal or molar correction. This is basically used when there is some kind of, this is basically settling elastic or class utilized in class 2 fashion. So class 2 elastic it can also be called a class 2 elastic. So basically we are pulling the canine in distal direction, upper canine, and lower molar in the mesial direction. So maybe some kind of discrepancy, maybe canine was here and they introduced this elastic, pulled the canine here so that it comes in its original class 1 position. Okay. So why this is class 2 elastic? Because it is bringing the canine from class 2 to class 1, towards class 1, or molar from class 2 to class 1. So whenever this, if the elastic was in this direction, this was class 3 because it was pulling the lower canine towards the back, hence bringing the class 3 canine towards class 1, hence class 3 elastic. Okay, remember that. Closure of anterior deep bite follows which principle? Boschinger effect, roller coaster effect, washboard effect, drawbridge effect. Okay, even if you do not know the answer for all of them, even if you do not know the answer, we remember that Boschinger effect is somehow related to the decrease in the hardness by bending the stainless steel in other direction. So Boschinger effect is not the answer. Okay. Then maybe roller coaster effect and washboard effect. These two effects are basically seen in fixed orthodontics. Okay. Roller coaster effect is basically, imagine this is your second premolar, this is your molar. Okay, my drawing is bad again. This is your canine. Okay. Okay, this is a wire which goes from here to here, and then there's a hook. Can I know? Molar also has a hook and a molar tube. Okay. You are applying force from here to here, which basically causes the wire to bend like that. The force was so high and the wire was so flexible that it bends. So why? Because whenever forces are being applied, there's mesial tipping of the molar, mesial tipping of the second premolar, and distal tipping of the canine. Okay, and hence the wire has a curve. So it looks like that you can drive a roller coaster on it. Okay, remember the roller coaster rides, it goes like that. Yeah, similarly the wire goes and the tooth also go. So they fall into extraction space. Imagine they are tipping into extraction space. Canine has to be upright. It has gone like that. Premolar has to be like this, and it has gone like that. Molar also has a longitudinal axis like that. Okay. So all of them tip towards the extraction space. That is roller coaster effect. What is washboard effect? Washboard effect. Washboard is basically a board of the washerman on which he washes his clothes. So he grinds his clothes on this washboard kind of things to clean them properly. Right? Okay. To clean them. He rubs the cloth on this. That is called washboard effect. This is the effect which is seen in the anterior, especially in class 3, or whenever you retrocline the lower anteriors too much. So what will happen is that when, see, imagine a teeth like that, you retrocline it in the lingual direction, they become like that. The root becomes, this is lower anterior, okay? So the root becomes prominent, right? So what happens in the anterior region? What do you see? Well, if you see the lower vestibule, you will see the prominences of the root of the anteriors. That will look like a washboard of the washerman. And hence that is washboard effect. So the closure of anterior open bite follows the principle of drawbridge. Okay. So like this is the bridge. Imagine if you tilt the screen, becomes like that. Okay. So once they move like that, so there is correction in the this thing. Okay, this upper teeth go back, and hence the open bite is closed now, and this is called drawbridge effect. Okay, this is a question which I asked previously and answered that as okay. But what I want you to remember, see, it has been given in pulse in the previous edition. The answer is something related to the bone growth. But I also want you to remember that whenever etching comes in option, I want you to take etching. Okay. That is a crystal growth is a modern technique. See, etching can be done through various means. Okay. Through laser also. So that is where we see a crystal growth technique. So the answer would be etching. Okay. Through laser, when we are using laser, now in that case, we see a crystal growth. So that is a technique which is associated with etching. If there is no etching in option, I want you to go for the answer which is previously in previous question I've asked you, and we have answered as bone growth. But if etching is present, go for etching. Okay. So that is the correction of the previous question. Okay. So yeah, that's it from my side. Thank you so much. Okay. See you later. Bye bye.